Chapter 9, Airway Management. Topics that we're going to cover is pathophysiology, physiology, opening the airway, obstructed airways, opening with adjuncts, opening using suctioning, keeping it open, and then special considerations. Airway physiology. The airway is divided into upper and lower portions. The upper airway begins at the mouth and nose. The pharynx lies posterior and inferior to the mouth and nose, which includes the oropharynx, the nasopharynx, the laryngopharynx, so the upper, middle, and lower portions of the pharynx. The larynx is the boundary between the upper and lower, commonly called the voice box. Here you can see the nasopharynx, the oropharynx, and the laryngopharynx. You can see where the epiglottis is that covers the air opening. You've got the cricoid cartilage, which is the largest part of your, the biggest ring in your throat, your trachea. Your esophagus is where your food goes. All of this is affecting your airway. So your jaw, your mouth, your tongue, you can see how large your tongue is there. Lower airway, trachea lies below the larynx. The mainstem bronchi branch from the trachea, and then it gets smaller and smaller and smaller until it ends as a bronchi, and then the alveoli at the end. Pulmonary capillaries surround the alveoli, and this is where the exchange of oxygen and carbon dioxide happen. Here you can see the right mainstem bronchus, the left mainstem bronchus. You can see how there's a little bit of a different shape. You've got more space here. This is where your heart's going to be. So there's got to be some movement so it can go around your heart. This here is the alveoli. You can see how they're little balloons. They basically fill with air, and then they can move air between one side and then the other. Airway structures in infants and children are a little bit shorter. There is a little bit of change in the movement of air. So there's going to be some narrowing. They've got this giant head that's going to make their airway a little bit more difficult to manage. You might have to put some sort of lift or block or padding behind their shoulders because their head is so large. Their tongue is proportionately larger to their small airway. They have underdeveloped muscles and bone tissue. So I talked about the rigidity of the trachea in adults with the cricoid cartilage. Children do not have that. They don't have the rigidity. So it's much easier to collapse and get squished or bent. Breathing is more dependent on the diaphragm because they don't have the muscles in their chest wall to be able to breathe adequately with their chest. So here's some anatomical considerations. You can see there that the adult, with the way he lays down on his back, his airway's open. But that kid, they basically need to have something underneath those shoulders to be able to make up that space because their heads are so much larger. Airway pathophysiology, patho being disease, physiology, so some sort of disease or ailment that changes the way the physiology or the way it works. So foreign objects can interfere with airflow, foreign bodies, food, small toys. They could choke on some their own vomit, some blood. They could drown. Loss of muscle tone, so they're unable to keep their airway open. They're choking on their own tongue. They're not awake enough to be able to keep that airway open. Obstructions can be acute or chronic, and it needs to be evaluated before, during, and after the entire patient care. Severe allergic reactions can cause anaphylaxis, which is a rapid swelling. Anaphylactic shock is the actual anaphylactic shock. You've got the swelling, and then you've got the altered mental status as well as hypotension. So think about different common airway pathophysiologies. Think about anybody that you know that might have allergies to peanuts or shellfish or something where they have to use an EpiPen. Think about someone that has other airway diseases like asthma or emphysema or COPD. We deal with people that have had burns to their upper airway, burns to their lower airway by inhaling hot gases. Blunt force trauma that can be damage to the chest, the ribs. Different infections can cause swelling of the tissues or in the glottic opening. You've got kids with epiglottitis. Their epiglottis is inflamed and could block that airway from being opened. So we also want to listen to lung sounds. If you can hear some of these outside without listening to the lungs with auscultation or with your stethoscope, this is all going to be on the upper airway. So stridor, high-pitched whistling, usually there's, it could be from epiglottitis, it could be something that has been partially swallowed and is stuck. Hoarseness, this is usually swelling around the vocal cords, very common in your burn victims, your burn patients. Snoring, you can snore during sleep, basically an indication that they are unresponsive or unconscious. And then gurgling is some sort of liquid in the upper airway. Is the airway open? And is it going to stay open? So the ability to speak is an indication that there is some movement of air and some sort of airway open. You still need to continue to reassess whether that airway is going to stay open. Stridor may be present on breathing in, breathing out, or both, and it is not good because there's air moving now, but one cough, one wrong move, and that blockage can be complete instead of just partial to where it's whistling. Breathing sounds from the nose and mouth should be free of sounds associated with gurgling, gasping, crowing, wheezing, and snoring. Some people use their body position to keep their airway open, so leaning forward with their hands on their thighs could be a way for them to kind of splint their airways open. Airway assessment is it's not just a moment in time, but it is constant. So we need to always consider airway breathing circulation. I know this is the airway one, but everybody dies from airway breathing circulation issues. If you stop breathing, you're gonna die. If your airway gets blocked off, you get strangled or you choke on something, you're gonna die. If your heart stops, you're gonna die. Everybody dies from airway breathing circulation, whether you bleed out from a car accident, you have a heart attack, you have a stroke, and your brain tells your body to stop functioning, stop breathing, stop having your heart beat at a certain amount of time. I mean, any of these things can cause death. Signs of an inadequate airway. No signs of breathing or air movement. Any evidence, you look in their mouth and you see food in there, you see vomitus in there. They're unable to speak or have difficulty speaking. Unusual hoarseness. And then absent, minimal, or even or uneven chest movement can be indications of an inadequate airway. Breathing movement limited just to the abdomen, so they're not able to use their chest wall. You don't hear any lung sounds on one side, the other, or both. You do hear lung sounds, but it's noisy. You can see retractions in some people. Retractions is where you actually see the skin and muscle tissue getting sucked in between the bones of like the ribs and the collarbone. In children and infants, you'll see nasal flaring. You'll see them open up their nostrils to try to get more air in. Opening the airway. You can open the airway with manual, so using your hands, using kind of gravity to help you open up the airway. If you do suspect trauma, you have to protect the head and neck, and you have to open the airway just a little bit differently. You can't do what is called a head tilt chin lift. You have to do what is called a jaw thrust maneuver instead. Unconscious patients, watch for indications of head, neck, and spinal injury. Continue to look for uneven pupils, look for decrease in mentation, increase in mentation. Look for respiration rates, and you'll learn this about Cushing's triad in your trauma, but pay attention to head, neck, and spinal injuries for unconscious patients. Some patients have open but threatened airways. They can always go unconscious. They can always develop significant airway problems. So somebody is having an allergic reaction and it's not anaphylactic at this time, but it could always turn into that later. Conscious patients, whatever is going to help them breathe, I try to get them in the position of comfort. Usually that's sitting upright on the gurney. So supine patients, 1 to 2 inches of padding behind the head can help put them into the sniffing position. It really depends on the anatomy and their head size. You might have to lift more of their shoulder up, especially in pediatric patients. So optimal position is when the ear is the same level as the suprasternal notch, which is that notch right where kind of where the collarbones meet, right above the sternum. You might not be able to get the position if there is some sort of C-spine or spinal injury. Patients without an intact airway require manual opening and ongoing interventions. It could be just as simple as diminished control of the tongue, so getting the tongue out of the way. Using an OPA or an NPA to be able to get the tongue out of the way. Using a head tilt chin lift maneuver or a jaw thrust maneuver, very commonly used to start your airway management. So the head tilt chin lift maneuver, you're going to place one hand on the forehead. You're going to lift that lower jaw by pulling up on the chin. You're going to move that jaw forward, and you don't want the mouth to close. So here you go. I mean, it's closed there, but it's not, you're not like squeezing it together. Mainly, so you're not putting pressure, let's see here, you're not putting pressure this way, you're putting pressure like here, up, and here. So head tilt chin lift. He's not putting pressure to close the mouth. Jaw thrust maneuver, this one you're not going to move the neck. With the other one you had a head tilt chin lift. This one here you want to pull the jaw forward. So right behind here, so the shape of the jaw, so the jaw is shaped like this, and you want to take your fingers and push the jaw forward. So not moving the neck. This is about like the sternal notch and the ear. So this is where all your patients are going to be, and then you're going to pull this jaw up and forward, and it pulls that tongue off of the back of the mouth. Obstructed airways. Obstructed, it could be a temporary and it could be more of a permanent obstruction or a chronic obstruction. We try to ventilate. If it's difficult to ventilate, we try to readjust, reopen the airway, and then continue to try to ventilate. Choking is classified as severe and non-severe, so it could be stridor, and then it could be fully blocked. Severe choking, trachea is completely blocked, no air is moving in or out. So that, remember, it was talking about how stridor is an ominous sign because they can have stridor and then eventually not have any stridor because it goes from non-severe to severe choking. Conscious severely choking, adults are treated with abdominal thrusts. You learn this in your CPR first aid class. Try to get the object out by forcefully moving air out of the lungs by pushing on the diaphragm. With infants, you're going to do back slaps and chest thrusts. So remember to use gravity to assist you in delivering those slaps and thrusts until the obstruction clears. Anytime anybody goes unconscious, whether they're adult or they're a baby, anytime they go unconscious, you have to start CPR on them. So if you cannot wrap your arms around the adult patient to deliver the thrusts, position the hands over the sternum. If they're unconscious or they become unconscious during all of these, you have to start CPR. Once they have the inability to maintain their consciousness, you have to start assisting their body and trying to circulate air that was in their body around and around. Airway adjuncts. There's manual maneuvers, which we talked about earlier, but they can get difficult and cramping on your hand. You need some sort of way to assist. It's not going to take over the airway, but it's going to assist you to hold the mask on, to be able to do other functions. So basic airway adjuncts is going to be your oropharyngeal airway. So oral being mouth, pharyngeal is that opening space behind the mouth, and airway. So OPA, nasopharyngeal airway, is in the nasopharynx. Both of these help to keep the tongue from blocking the airway, basically when somebody is unconscious. Since the OPA goes into the mouth, we do not want them throwing up. And anytime you put your finger in your mouth, you put something in your mouth like that, they could gag. And so if the OPA is not tolerated, we'll have to use an MPA instead. For using an airway adjunct, if they start to gag while you're putting in the OPA, stop. Try to maintain head position before, during, and after the airway insertion. The airway has to be monitored all the time. You have to be able to provide suction if there is fluid that starts to develop. If the patient regains consciousness or develops a gag reflex, you have to be able to take the OPA out immediately. OPA is curved plastic. There's going to be pictures of this. They do range from size infant to an adult. There is another video I have about OPA. It is available on another channel. Let's see here. Should be pictures of it. There you go. So down from infant size, and I think they even get like super small, like this size, like horrible, like I never want to use them, up to the big, large size. And you're going to size these by using the tip of the ear to the center of the corner of the mouth. So I think OPA goes from tip of the ear to the corner of the mouth because that's where it goes, is the mouth, and it needs to follow the jawline. So, or you can go from center of the mouth to the angle of the jaw and the lower bone. I like to do earlobe, corner of the mouth, because your NPA is also from the earlobe, but to the nose. So earlobe to the corner of the mouth, this is the size that's going to be appropriate. Or you can do center of the mouth to the angle of the lower jaw. So the lower jaw has like an angle here. It does this like bend. And so the center of the mouth. But some people have big like jowls or some sort of like beard, so it's a little more difficult to see. Thus, that's why I like to do the earlobe to the corner of the mouth. Steps for inserting an OPA, you need them on their back. You need to do manual airway opening, whether the head tilt chin lift or the jaw thrust maneuver. You're going to open the mouth using a cross-finger technique. You don't want to put your fingers in the mouth. They could bite them off. You're going to position the airway with the tip pointing toward the roof of the mouth. So it'll look kind of upside down. Let's see here. So you've got your person's face here. So there's the eye. And you've got their mouth. Stop it. Got their mouth. And then you're going to put the OPA in this direction. It looks like it's upside down, right? So this is their, man, I'm a horrible artist. There you go. So it's going to go in upside down like this at first. We have what is a hard palate is right here. You're going to put it towards that. And then once you put the device in, you'll be able to rotate it around. So this is the cross fingers method. If she bites, the fingers are going to be able to be pushed out so they don't get bit. Putting it in upside, what appears to be upside down, just to get it in, and you're going to get past like the teeth, and you want to get past the tongue. And then you're going to rotate it 180 degrees so the tip is pointing down the pharynx. So it's going to be more anatomically correct. You're going to want the flange, or that wide spot at the top, to be resting against the patient's lips. And then you're going to want to monitor the patient closely, because as you provide them oxygen, they may start to wake up. The NPA is used when there is a gag reflex, so they might throw up. You're unable to open the airway, or there's some sort of facial, like oral injuries. You cannot put it with the like nasal injuries, especially if there's like nose trauma or a basilar skull fracture, because you don't want to put that NPA into their brain. We want that to go into the pharynx. So measuring an NPA, remember the OPA went from tip of the ear to the mouth, and the NPA goes from the tip of the ear to the nose. That way you can remember easy. So ear to nose, ear to mouth, and don't like straighten it out. It's going to have a little bit of a curve. You want to make sure that it maintains a little bit of that curve. You will want to lubricate the outside of the tube with a water-based lubricant. Most of the time they come in with like the kit that'll be on your ambulance. They'll be kind of together, and it's just to make it so it slides in a lot easier. You want to point the bevel, or like the opening part, towards the base of the nostril, like basically towards the septum, regardless of what side you're going to put in it. I know it's going to look like it's upside down, but it will rotate as you insert it. So here you go, measuring from the tip of the ear to the nostril. See how it's got that curvature? He's not stretching it out straight. Lubing it up, and then inserting it. You have the bevel side towards the base of the nostril, or towards the septum, and then inserting it in. Don't force it. If you have some like block, don't force it in there. Try the other nostril. And again, he'll just rotate it around to where the bevel then again faces the septum, so it'll look like it'll be going upside down to her brain, but it won't. I mean, I promise you it will roll around. Insert it to the nostril, advance along the floor of the nasopharynx, and the flange will rest firmly against the nostril. Supraglottic airways. A lot of places are going to what is called an I-gel. It is a supraglottic, so supra meaning above, glottic is your epiglottis, so it goes just above the epiglottis, and it essentially blocks off the spaces above it, so in the pharynx area, and it tries to plug off the esophagus to where the only place the air can go is going to be in the trachea. So it doesn't go into the trachea like an endotracheal tube does, so endo being within trachea. So endotracheal tube is within the trachea tube. It's not one of those. This one's a supraglottic, so above the glottic. I-gel and King Airway differ a little bit, but most of the time it's going to be the same as like just preparing the patient, getting your equipment ready, pre-oxygenating the patient. You need to prepare who's doing what. Assign somebody that's going to do suction, assign people that are going to do testing of equipment or insertion. You need to prepare a team, because you're going to be taking over a person's airway with this device. So prepare the device. You're going to size it per the manufacturer's instructions, whether it's the King Airway or the I-gel. Back in the day, we used a combi tube, which is very large and bulky, and I don't think anybody uses the combi tube anymore. You need to have suction ready, because this is going into their mouth. Same rule applies with the OPA. If they start to have a gag, you can't continue this airway. Suctioning. Foreign materials in the airway need to be suctioned out. If you're using suction, try to clean your tubing out. The biggest thing is, so you start sucking out, you're getting all in there, and you get gunk in that tubing, and when you want to use it again, that gunk is now dried and blocked your suction tubing. So you want to make sure when you do suction, you have like some sort of water next to it, some sort of clearing to be able to clear your tubing out. You can tilt the person to the side to allow fluid to drain out, but it needs to be done with a partner to be able to get the whole body to move, make it safer and easier for you and your patient. Always turn the patient away from your body. Always turn them towards your partner, because that's where you want the vomit to go, is on you and not them. Or on them and not you, sorry. Actually, don't ever tilt a vomiting person over onto your partner. It's rude. Suctioning uses a vacuum to remove foreign objects. You should, understand that how suction is. You need to have a source. You need to have somewhere that the container is, some sort of tubing, and then the tip itself. There is vehicle mounted and onboard units. It uses the vehicle's power to be able to create that suction. It can take a lot more volume most of the time, and can have quite a bit of suction strength as opposed to some of the manual ones. They do have ones where you grip it with your hand, and that creates the suction. Portable suction units, that's what I'm talking about there. They could be oxygen or air powered. It could be electronically powered. Many of them have a battery that have to be charged. And then there's the manual ones. So here is a mounted suction. You basically can turn it on. It will provide suction at this strength here. This here is the tube that goes into the person's mouth. So goes into the mouth, it gets in here, goes through all those tubings, and then goes into this tank. So you're going to want to, all of this tubing here that's wrapped around it, that goes into the tank, you want to suction, you want to clean out so it doesn't get all hard and crusty and gross. Suction unit requires tubing, tips, catheters, collection, and a container of clean or sterile water to be able to clean it out. The Yankauer tip or the tonsil tip is usually the most common for adults. It's the most popular. It's rigid. It allows control to be able to get down to the back of the mouth, even behind the back of the teeth. It's most successful with your unresponsive patients. It's very similar to when you go to the dentist and they use that to suction all the extra spit and stuff. They do have flexible tubes that are a little bit smaller. They can go into the nose. They can go into your advanced airways, your airway adjuncts. So the flexible tubes are a little bit smaller, but you don't have the control like you do with the Yankauer tip. The collection container, you don't want it to be like a Ziploc baggie. You want it to be able to be non-breakable, but yet easily removable. Infants are very sensitive to vagal stimulation. That's when their heart will slow down. So we want to make sure that we have like eyes on their heart rate. We have monitoring on them at all times so we can see if their heart rate is getting slower. We can use the bulb syringe suctioning instead of a large machine. It is very easy to use it. A little easier to maintain, less likely to oversuction. You need to make sure you have the correct PPE on. If you're suctioning, that means that there's fluid, that there's liquid, that there's something. So you need to protect your eyes because you have mucous membranes in your eyes. You should have a mask on so you don't get stuff in your mouth or in the mucous membranes in your mouth or nose. And you need to have gloves on. So suctioning technique here. She's getting the equipment ready. He's providing blow-by because if there's fluid in the mouth, you don't want to push that fluid into the lungs. So if you turn their head to the side, if you're able to turn it and there's not a spinal injury, it's easier because then only half the airway is being affected. So definitive care. Sometimes definitive care is going to be higher than the EMT1, but you're able to assist your advanced life support personnel. You might have to bag for them with when they put an ET tube in. You need to get them to more definitive care. If you have to put an airway in, they need to go to the hospital. There's no reason this person should be refusing. Special considerations. Facial injuries, this could include bleeding in the airway. It could make it to where it's difficult to put a bag on. It might be difficult to move a jaw to be able to put an OPA in or even a supraglottic airway. There could be obstructions. You might not be able to get some of the solid objects out. Do not do blind finger sweeps. Use abdominal thrusts when they're conscious. Use chest thrusts on your infants. Start CPR when they go unconscious. Do what you can to try to get the obstructions out, but don't do blind finger sweeps because that could actually push whatever the object that was almost out back in. Dentures should be left in place during airway procedures. If they do become dislodged, you can take them out, but when you take dentures out, now it leaves a lot of extra space and loose flapping lips, and actually make it harder to be able to ventilate. So, airway is the passageway in which air enters the body during respiration or breathing. You cannot survive without airway breathing circulation. So this one is all about the airway. Airway adjuncts for basic airway is your OPA and your MPA. They basically help keep the airway open. They do not take over the airway. You still have to maintain some sort of manual control. You may have to suction throughout the entire call. So being prepared, being ready to be able to shift the patient to the side, having suction units ready, and having communication with your team about who's going to do the suctioning, who's going to do the artificial ventilation, and vice versa. Always use proper PPE. Protect yourself from fluid and gunky and grossness. Airway assessment is before, during, and after. You need to be able to assess the status of the airway throughout the entire call. Can you name the main structures of the airway? Think about how air passes through. So the mouth, the nose, think about your mouth breathers. They might not be able to use nasal cannula if they breathe through their mouth all the time. If there is somebody that had some trauma to their face, think about how you're not able to now use an MPA or an OPA if it was their jaw. Being able to describe the signs of an inadequate airway, what the difference between stridor and gurgling is, what you're going to do if you hear stridor, what's the step that you're going to take if you hear stridor, what's a step you're going to take if you hear gurgling. When you're given a patient on any practicals or even in real life, and you get to the side and the first thing you hear or see is gurgling, then you know you have to fix the airway as you find it immediately. You have to fix breathing the second you find it, and you have to fix the circulation the second you find it. Know the difference of a head tilt chin lift versus a jaw thrust maneuver, and how to be able to use it and why. So on arrival at the emergency scene, you find an adult female. She's gurgling. What do you do? How do you fix gurgling? inadequate breathing is slowing to almost nothing. So you can't start breathing for her until you get the gunk out of her mouth. So you have to suction first before you start putting air into her lungs. You hear stridor when you're next to a small child. What does that tell you? What are some immediate concerns regarding stridor? Remember, it's very ominous, and stridor could develop into no sounds at all. So being aware that those airways can continue to swell, or whatever it is that was partially lodged becomes fully lodged. You're assessing an unconscious patient, you note snoring respirations. Remember, snoring is usually from a lack of muscle tone. So there are some ways that we can assist. And usually with the muscle tone is going to be your head tilt chin lift or your jaw thrust maneuver. Typically just a better positioning or an insertion of an OPA or NPA will resolve this problem. Hopefully you guys enjoyed this PowerPoint, and I will see you next time.